Welcome to the AETCM YouTube channel. Today we are going to discuss a case of a pneumothorax. Ma'am, shall we start? Ma'am, today we received a patient in the first initial 10-second assessment. Patient is talking the one whole full sentence. Patient
What was
looks.
the initial history when you got while the patient was received to ER?
Patient has an initial history of patient having increased shortness of breath. Patient has a baseline of breathlessness,
Mm.
increased breathlessness history, and a known case of carcinoma lung.
Okay, okay.
That is the initial history. And in the first 10-second assessment, patient was talking in one full sentence. Patient was looking in normal color and he was normally oriented. Coming with the primary survey, patient was able to talk in one full sentence, no gurgling or stridor or no hoarseness of voice, no pooling of secretions, and no any foreign body anything. Coming to the breathing, respirate is 20 per minute and saturation is 95% on room air. And regarding the chest movements, it was asymmetrical chest movements were noticed, right side more than the left side, ma'am. And the air entry is reduced on the left side, and bilateral wheeze was also present.
Bilateral visa, sir.
Bilateral wheeze was there.
Mm.
And regarding the
So respiratory it was only 20.
yes, ma'am.
Okay.
And after that, coming to circulation part, patient has a normal skin color, palpable peripheral pulses, and less than 2 seconds of CRT. Heart rate was 88 per minute. Blood pressure is 140 by 80. At this point, two large IVR cannulas were inserted. And regarding the disability, GCS was 15 by 15, and bilateral eyes were equal in size 2 and equally reactive. Regarding exposure, temperature of the patient was febrile and hypothermia was prevented and GRBS was 106 mg per dl. Regarding the adjuncts for the primary survey, we got an ABG which was showing no acid-base disorder. PCO2 was 31.5 and PO2 was 60.5 in this patient with pH being 7.49.
Slightly on the alkalotic state, respiratory alkalosis.
Respiratory alkalosis. And regarding the point of care CBC CRP was taken, ma'am. The WBC was 9.6 and hemoglobin 15.5, CRP of 37, platelets 260, slightly like infective pathology was there. So in cut short, summarizing the primary survey, the patient had left-sided reduced air entry with normal vitals of respiratory and BP and everything. Stable patient in short.
Okay.
Now coming to the secondary history, sample history, ma'am. Patient is a 77-year-old male with a known case of right upper lobe non-small cell carcinoma, status post right upper lobe lobectomy. Along with that, patient is a known case of COPD also, ma'am. His baseline MRC grade 2 dyspnea was present, ma'am. Now the presenting complaint was dyspnea worsening within the last 3 days. Along with that, there's a left-sided chest pain and heaviness which started 3 days back. And the dyspnea increased on exertion. Right now it's MRC grade 4 and no orthopnea or PND like features. And no any history of cough or fever, but there is a mild sputum with whitish yellowish color. That is this on examination, patient is conscious oriented, no pallor, icterus, lymphadenopathy, cyanosis or edema. Ma'am. Clubbing was present grade 2. And patient's chest examination, there was reduced air entry on the left side. There were bronchial breath sounds and bilateral air entry, like left-sided air entry was reduced.
Okay, that was fine.
That was
So if we are getting a patient with left side air entry reduced, what else should we check?
Initially, we need to check for as an emergency condition. We need to rule out pneumonia.
In inspection, what all things will you check?
Inspection, we will check for any chest raise,
Chest raise. So
asymmetrical
chest raise was reduced on the left side. It was more on the right
right
side.
side.
Then
Inspection is
then
tracheal deviation we will check.
was it there?
Significant, not a significant.
No
Inspection,
significant. It was not there. Okay. Palpation.
Palpation wise, again checking the tracheal positioning was in the central midline itself, ma'am. Apart from that, on palpation, checking the again asymmetrical.
This patient had right lobectomy, so the chance of the trachea might be shifted to the left side. So this patient, it was normal. Why it was normal? Can it be because of some pathology in the left side?
Yes, like in pneumothorax.
Okay, okay. In pneumothorax, pleural effusion, massive pleural effusion, everything
trachea goes to the opposite
opposite
side.
Okay. Right side lobectomy is somewhat equal to right side collapse or fibrosis something. So the trachea will have a tendency to get shifted to the other side. So this side, this patient citizen center means there can be a pathology in the left side.
Yes.
Okay. Then what else should we check?
We should have gone to the bedside
What about the percussion?
Okay, percussion. Regarding the percussion, there was dull. I mean,
What percussion findings will you get in pneumothorax?
nothing.
Nothing.
Hyper resonant would be the.
Hyperresonant note will be seen in pneumothorax. What about suppose this patient is having massive effusion? What finding will you get in percussion?
Massive effusion, dull. Pleural effusion.
Stony dullness. Stony dullness. That is how we differentiate it from a pneumothorax or effusion. So if it is air, it will be hyperresonant. If it is fluid, it will be stony dull. Okay. This patient that was not checked. Okay. What did you check then?
Then auscultation basically.
Auscultation, errand was reduced. Okay. What about the wheezes?
As a COPD patient, and he was having wheeze, and there was an infective recent acute exacerbation of COPD kind of picture.
Okay. So you have a patient with reduced errand on the left side. What next investigation will you do other than the primary survey, ABG, these things? Suppose X-ray is delayed. What else you do?
Bedside lung.
Bedside lung ultrasound. Was it done for this patient? Okay. What will be the finding in bedside lung ultrasound?
Basically, in the lung ultrasound, we will see that the pleural layer moving with the respiration, causing a seashore kind of a sign where above it. So,
which probe will you be using to do bedside lung ultrasound? We have 3 probes, right? A cardiac probe is there. Then we have a curvilinear probe and a vascular probe. Which probe will you use? Vascular probe. So what is the hertz frequency for that? It will be around 5 to 12. And the echo probe and all, the cardiac probe and all will be having a low frequency. The frequencies will be from 1 to 5, that range. Even the curvilinear probe will be having that frequency. This is somewhat a superficial probe. Okay. So where will you keep the linear probe?
For like each lung will be divided into 10 segments, and we
first we will be checking it below the clavicle. So what will you see first?
First we'll see the bright white line pleural line, which is
okay. So if this is the lung ultrasound, we will be seeing first we will be seeing, so we will be viewing it from here. We will be seeing the chest wall here, the intercostal muscles will be seen here, and here one white line will be seen, that is the pleural line. Okay. And below here you can see 2 black areas. What are those?
Ribs.
And these are the rib shadows. Okay. So normally when you see, you will be seeing this muscles and one white line. From here the lung starts. Okay. This is a pleural line. From here the lung starts. So this is known as a bat-wing sign. Bat-wing sign in the sense, these are the wings of the bat, and this is the center portion of the bat. Okay. And if you are seeing it in a normal lung, if you are seeing it like this, you will be seeing a pleural line, and this pleural line will be shadowed here like this, and another will be shadowed like this, like equidistant from this pleural line. This distance and this distance will be same. These are the A lines. This is a A profile. This is actually normal. A profile means A is air. This is normal. This can be seen in normal lungs. Or if the patient is having some, if we are seeing A profile, then we will have to, if we are if this patient is having breathlessness, other findings and all, we will have to look for any DVT scanning, other things, to look for some other cause like pulmonary embolism and all. So A profile is usually normal. Okay. Then what mode is this one?
M mode.
M mode. So when we put this patient on M mode, what is seen here?
This motion of this, with movement of the pleura along with the lung movement will be seen.
When we are checking it like this, before putting to the M mode, if we are directly placing the probe here, we will be able to see this pleura moving. That is called as a lung sliding. This lung sliding will be absent in which condition?
In pneumothorax.
In pneumothorax, lung sliding will be absent. Okay. So if it is normal, what will be seen here in M mode?
In M mode, we will see that above it would be like plain lines, and down it will be disturbance lung
No.
movement.
Above, what is happening is, so normally what happens, the pleura is moving,
Moving.
during breaths.
Inspiration,
Okay.
expiration.
So what is happening is, this portion will be moving,
Yes.
and this will be this will not be moving.
Mhm.
So what we will see in normal scenarios, we will be seeing some lines like this in M mode, and here we will be seeing lot of dots.
Dot.
What is this called as?
Seashore.
This is seashore sign.
Seashore.
This is the sea with the waves, and these are the dots. That means this portion is not moving. This is moving. This, since it is moving, it is like somewhat like a hazard. Okay. 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 But if this patient is having pneumothorax, our patient is having pneumothorax. So so in pneumothorax, nothing is moving. Not even this part or this part. Nothing is moving. So everything will be lines. Okay. So you can see the lines here. Only lines are there, no dots. If this portion is moving, then you can see some dots. That means the shore will be seen. So here only the sea is seen. What is this lines called?
This is stratosphere.
Stratosphere sign or
the barcode sign.
Barcode sign. Okay. Suppose this patient is having, so our other DD was what? Pleural effusion, massive. What will you see in this lung ultrasound? B profile, and will you see B profile? Pulmonary edema. B is, what is B? B means interstitial pattern. Interstitial pattern. Okay. So B profile, how
the
will
lines
you see?
will be broken like.
How will be the lines?
This plural line, these air lines will not be continuous. They will be broken, and they will be shadowing of it. Will be there.
What will be saying? You are seeing a profile here, right?
Okay.
Here you will be seeing rocket-like
Rockets.
waves going like this. This is the B profile.
profile.
It is not seen in effusion. It is seen in what? Which
Edema.
condition? Pulmonary edema. Pulmonary edema
edema.
and some sort of consolidation. But if this patient is having effusion, what else will be seen? Where will be the effusion be?
Between the pleura and the lung.
Pleura and the lung.
Here.
So somewhat in this area there will be effusion. So we will be seeing black area here. This portion will be black here, and from here the white line of the pleura will start. So this will be seen as a quadrangle shape or a rectangle shape. So this is called as a quad sign. Quad sign. That will be seen if you are placing the linear probe here. Okay. Simultaneously, if we are keeping the patient in M mode, what will happen? This patient is not having pneumothorax, so this portion will be moving. Which portion? The lower portion will be moving. So when
shore will be there.
Shore will be there. Along with that, since there is fluid here, you will be seeing a black line going, and the lung is moving here. So you will be seeing like this. So this black portion is the fluid here, and the lung below it is moving. So this will be the seashore here, and this will be the muscles. The straight lines will be. So this sign is called sinusoid pattern. Sinusoid pattern. So in effusion, we will be seeing a quad sign and a sinusoid pattern. Okay. Along with that, if it is a massive effusion, if we are keeping the curvilinear probe in the flaps point or below the axilla, we will be seeing what? We will be seeing effusion. Then
the
diaphragm will be seen. So we are using a curvilinear probe. So we will be seeing the effusion here. Something like this will be seen. What is that? Collapsed. This is effusion. This much area effusion is there. Okay. Effusion is there. Here we will see the collapsed lung. Collapsed lung will be there. Then we will be seeing the diaphragm. If it is left side, we will be seeing the spleen here. Okay. This much area will be black in color. That is the fluid. So what will be this collapsed thing? The collapsed lung. What is that called? The fishtail sign or the jellyfish sign will be there. That is the collapsed lung. That is seen with the curved probe, not with the straight probe. Okay. Now you told about B line. Another profile is C. What is C? A for air, B for interstitial pattern, C for consolidation. Consolidation. Okay. So, what are the stages of pneumonia?
Four stages.
Four stages. One is stage of congestion. Then
Congestion,
red hepatization, gray hepatization, and resolution. So, red and gray hepatization is there. What do you mean by hepatization?
Like liver,
It will look like liver. So, suppose we imagine one patient is having right side consolidation. Okay. So, right side consolidation is there. Along with that, the patient, this is the diaphragm, patient is having liver. So, if we are keeping the curvilinear probe here, we will be seeing a liver-like pattern of the lungs. So, how the liver looks, the lung also will look the same. That is what is called as hepatization. Along with that, this sign is called as, in ultrasound when we are looking, that sign is called as tissue sign. Tissue sign, okay. Tissue sign. But simultaneously, we will be seeing some rocket-like thing going, like our bee line, some rockets will be going. That is called as Shrek sign. That means because this lung, this disease lung and the normal lung, all these contacts are coming. So that's why there will be a air fluid interface happening. So there will be some rocket-like patterns in that is called as a Shrek sign. Okay. This much things will be seen in ultrasound. Okay. Lung ultrasound. Okay. Right. Then what happened to this patient?
Basically, the diagnosis made because it's a COPD patient and pneumothorax.
One more thing is there. Pneumothorax, what all things we told? Absent lung sliding, barcode said, and one more we will be seeing. Lung point. Lung point. Lung point. Lung point is what? Lung point is one area. Proximal to that area, that means the point where the pneumothorax starts. That is called as lung point. So, if this is the lung point, this much portion will be moving, this much portion won't be moving. Okay. So this much point, if you're checking this much side, it will be like
seashore,
half seashore and half barcode sign will be there. That is a lung point. And if we are, so I told that normally air, if it is a aerated lung and pleura is moving, that is called as A profile. In case of pneumothorax, that profile is called as an A dash profile. A dash profile, that means pneumothorax. Okay. Okay. Then how did you diagnose it as pneumothorax?
Taking
X-ray. Okay. Okay. Explain.
This part of the X-ray where there is lung tissue.
Okay, lung tissue is in this. So you can see the air here. You can see the black area here, very translucent area here. Here there is no bronchoscopy markings or anything here, and you can see a clear demarcation here, and this is the pneumothorax. Okay. So what was done for this patient?
On identifying this, and we need to compare with the stability of the patient when we see this. Criteria for the stability of patient in pneumothorax, we'll see if the respiratory rate is less than 24 and shortness of breath is not there at rest, pulse is more than 60 or less than 120, and normal BP, oxygen saturation is maintained greater than 90% on room air, and absence of pneumothorax. In view of these all the factors, if the patient is stable, immediately there is no indication for a ICD insertion for
this patient. Is there any indication?
Dyspnea at rest, it is there.
Dyspnea. Okay. This patient, stability wise, patient is stable. Okay.
Vitally, he was stable, but dyspnea, impending kind of an tension pneumothorax, as it is a COPD patient with bulla open communicating. The air can be continuously increasing, and we can expect it to form tension pneumothorax. So, in view of which ICD insertion was placed.
So otherwise, so you stand here.
Yes.
Okay. So we have a patient with pneumothorax. Okay. When will you put ICD? First one you told, what is it?
First one, instability.
So unstable patient. Unstable patient. Directly go for ICD. Then when you place ICD?
Second, impending pneumothorax.
Impending pneumothorax.
Actually, impending tension pneumothorax.
Okay. If it is like spontaneous pneumothorax, we are not discussing about any traumatic cases. Spontaneous pneumothorax, if the patient is unstable, we will have to put ICD. Then this is bilateral pneumothorax. If the patient is coming with bilateral pneumothorax, we will have to put ICD. Then we will have to divide this patient into what?
Size.
Primary or secondary? Primary or secondary? So which all patients will go into primary, which all will go to secondary?
Primary is like long, tall, and
primary is less than 55 years.
yes.
This is more than 55 years. Okay. Then primary means no significant smoking. Here there will be significant smoking. Okay.
And underlying lung disease secondary.
Third one is underlying lung disease. Okay. These three things, if any of the three things are there, then this patient will go into secondary. Okay. So this patient is primary or secondary? Secondary, because this patient is having CA lung, patient is having COPD.
And is chronic smoker.
Chronic
greater than 65 years.
So if we are having a young male coming with pneumothorax, it will be mostly primary if he is not a significant smoker without any lung disease. Okay, then how will you decide whether to put ICD or whatever to do for this patient?
Depending on the size.
Depending on the size. So where will you measure the size in this?
From the hilum.
From the hilum. Where is the hilum? Okay, from the hilum we will be measuring the size. So hilum we will be measuring the size of the pneumothorax and
depending upon if 2 centimeter.
2 centimeter or not. Okay. So primary pneumothorax more than 2 centimeter, and if the patient is having shortness of breath, then this patient what he will do? Needle.
Needle therapy.
Needle decompression is done for which condition? Tension pneumothorax, traumatic tension pneumothorax. Here we will have to do needle aspiration. Needle aspiration. So what is the needle size you will use here? 22. 20 is not wide bore, no? We will have to use 16 to 18 gauge should be used. Okay. If it is like needle decompression in case of traumatic cases and all, needle decompression we will be doing for tension pneumothorax now before placing ICD. That we will be using 14 gauge and all. So where will you do needle aspiration?
In triangle of
needle
aspiration
in traumatic needle decompression, we will be doing it in the fifth intercostal space in the midclavicular line. Needle aspiration can be done in the second intercostal space also. Okay. So we can aspirate up to maximum of 2.5 liters. Okay. This is only indicated if the patient is having more than 2 centimeter size and shortness of breath. Otherwise, any patient less than that or without any shortness of breath, what will you do?
Without it, we will plan for the
conservative management only with oxygen support. All conservative management. If very stable, we can discharge also. Okay. So our patient is secondary pneumothorax. Okay. Secondary pneumothorax, what will you do? Secondary pneumothorax.
Secondary, depending results again on the
size. What all sizes there can be? Okay, more than 2 centimeter. What will you do?
ICD.
Okay, ICD. Then 1 to 2 centimeter.
Needle
aspiration. Needle aspiration. Same as that of the other one. Needle aspiration. Less than 1 centimeter.
Conservative management.
Admit the patient. Start on oxygen. Follow up the chest X-ray. And if at all it is worsening, then we will have to decide. Okay. What was done for this patient?
In view as this is more than 2 centimeters and this is secondary spontaneous, we plan to go ahead with the ICD tube insertion.
Was it inserted?
Yes. Inserted in the fifth intercostal space and the triangle of the safety.
So what are the borders of triangle of safety?
The triangle of safety border, the base of the axilla, lateral edge of the pectoralis major, and the lateral edge of the latissimus dorsi. And the base would be the fifth intercostal rib, fifth rib.
Okay. How will you place ICD? How will you select the ICD tube?
ICD tube.
The size of the ICD. So we are planning to place ICD for a patient. Okay. So we are having different size of ICDs. How will you decide the size? So we are having hemothorax or there can be massive pleural effusion. there can be pneumothorax. So
there we require wide bore.
Why wide bore is
for
required?
the fluid to come out.
For the, if it is like hemorrhagic, traumatic and all, there can be clots and everything. So we need wider bore for which one?
Clots to come out.
In case of effusion or a traumatic hemothorax.
Yes.
Whereas in pneumothorax,
smallest
required. So in this condition, what will you place? What
smallest
can be placed. So if it is a spontaneous pneumothorax and all, we can prefer from sizes from 8 to 14 fringe size can be used. If it is like traumatic pneumothorax, this we are talking about pneumothorax. Traumatic, we can place from 18 to 24 size French ICD can be placed. Okay. Otherwise, if it is a hemothorax or a massive pleural effusion, we need a bigger size from 28 to 32, that much size we can use. Okay. Wider bore should be used. And if you are planning to place ICD, how should the ICD be directed?
In case of pneumothorax, it should be directed upward.
Why?
Because air would be collecting in the upward. If it is hemo or pneumo, it should be placed downward.
Downward. Why downward?
Fluid will be
dependent
on the.
Okay, so how did you place ICD for this patient?
Steps wise, first we need to select the site of the incision by the site of the incision will be usually in the upper border of the lower rib.
Why?
Because in the lower border of the rib there will be the neurovascular bundle, so there will be chances that we'll.
Okay.
So upper border of the lower rib we should feel and palpate the space and select that. And we need to check along with the ultrasound probe to check if there is any lung mass. So that it would not be going into the lung tissue. After that, first step would be the local anesthesia, and the second step would be the skin incision at that site.
So how will you incise the skin? These are the two ribs. How will you incise the skin? What incision is this? V incision is not allowed.
Single incision.
Single linear incision parallel to the rib.
Yeah, parallel to the rib.
Okay. Here or here? Here or here?
Here. Upper of the lower.
Okay. Then
we dissect into the pleural cavity.
How will you dissect into the pleural cavity?
With the forceps.
What forceps? You will be going with the scalpel inside or with the forceps inside?
Only with the forceps.
Only with the forceps we will have to dissect. With the artery forceps we will have to dissect. Then
we'll place the tube.
How will you open the pleural space?
First dilator we use the dilator to.
What dilator you will use?
The tube dilator.
Either we can, with the artery dissecting forceps itself, we can poke into the pleura and we can open that and we can insert our finger into that and we can insert the tube. Or it is not safe to do with the trocar. With the trocar itself, we can directly poke and go enter into the pleural space. Okay, fine. Then how will you secure the tube?
With the help of the air bubble.
The help of?
Air bubble, the water fluid level. Secure the. Sorry. We secure it by stitch.
Immediately after inserting the ICD tube inside, we will have to connect it to what?
Water level.
What is this? Underwater seal. So if you are planning to put an underwater seal, how much ml of water should be there? Underwater seal means there should be sterile water. How much water should be there? Minimum 100 ml of water should be there. Okay, so immediately after placing the tube inside, we will have to connect to the underwater seal. Otherwise, what will happen if you are simply letting it open?
The
air will again get inside. So that will cause tension pneumothorax. So you don't want that, you will be there. So once it is in place, what will be seen?
Air bubble movement.
Air bubbling, initial gush of bubbling will be seen, and after that we can see the air fluid movement will be seen in that. Okay. And how will you secure this tube? How will you suture?
We have to tie it across the skin.
We will have to take the bites from the skin and we will have to directly tie it onto the tube. Will you take bites from the tube?
No.
What will happen if you take bites from the tube? Again, air will leak inside. Okay. So careful. What suture material will you be using? Usually for simple suturing and all, we will be using ethylone and all. These things are not very good for this. These might break. So this will be better. Okay. So was ICD placed?
Yes. ICD was in position and then the pneumothorax was resolved.
Okay, okay, okay. Then what happened to the patient?
Then actually the patient, the bulla has been ruptured as per the X-ray and CT finding, and there is a day to the pneumothorax was still persistent.
Okay.
So in view of this continuous this pneumothorax as a risk factor, talc pleurodesis was performed. The pleural layer was closed with the help of talc, and patient was discharged stable.
So when else will we plan on doing pleurodesis and all?
Effusion or
Effusion. This patient is already having malignancy. So suppose this patient is having the right side malignancy, and this patient is always having a right side pleural effusion. Recurrent effusion is there. This condition also we can do talc pleurodesis. Okay. Thank you.